This is Pat Walter from the Surface Hippie website.
Hi, Pat.
Doing Dr. Brooks from the Cleveland Clinic, and we're in Baltimore, Maryland at this time. Dr. Brooks, could you tell us how many hip resurfacings you have done to date?
Yeah, at this point I've done over 450 hip resurfacings in the 3 years since I started doing it in 2006.
Could you tell me what device you normally use?
Every one that I've done has been the Birmingham hip resurfacing. That's the device that I chose because it was the first one approved in the United States. And I'm glad I chose it because the data from around the world, not just from Birmingham, but from Australia, early US data, European data, Scandinavian data, is pretty consistent that the Birmingham has the best long-term results.
Could you tell us a little bit more about the Cleveland Clinic and hip resurfacing?
Sure. Right now, Cleveland Clinic is one of the main centers for hip resurfacing in the United States. We opened an administrative structure we call the Cleveland Clinic Center for Hip Resurfacing. It's based at Euclid Hospital, which is a suburb of Cleveland where I do most of my work. It is part of the Cleveland Clinic, and we have the three aims at the Center for Hip Resurfacing that the Cleveland Clinic has in all of our endeavors, which is outstanding and excellent patient care, research, and teaching of residents and other surgeons who wish to learn techniques from us.
What approach do you normally use, and why do you think it's a benefit to patients?
You know, I think in general a surgeon who's starting on a new procedure, and in the case of hip resurfacing it is a more difficult procedure, they should use the approach that they are familiar with already when they do hip replacements. And I have always done hip replacement surgery through an anterolateral approach, and that's how I started doing hip resurfacing. About 80% of surgeons in America do it through a posterior approach. 20% do it through one form or another of the anterior approach, like I do. That situation is different here and there around the world. In Canada, Australia, Europe, there are more people doing it through the anterolateral approach. And I can tell you, it makes sense to me. The blood supply of the head of the femur is primarily a posterior blood supply. And so when I go in the front of the hip, I'm really not touching that blood supply. And although there's never been any clinical outcomes data or research or anything that proves that the final results and the outcome are different depending on what approach you use, it makes sense to me to stay away from that important blood supply, because if you damage it, then the bone in the femoral head could die, and that could have some implication in the future, the same way avascular necrosis of the hip is a disease. Now, I could also say that the bones of the hip, both the acetabulum, which is the socket, and the femoral head, which is the ball, are anteriorly facing structures. So when I approach the hip from the front, I'm already looking at them, so there isn't as much of an extreme positioning, at least in my view, doing it anterolateral than there would be if I did it posterolateral. And I could point out that as a resident I was trained to do posterolateral hip surgery, so I am familiar with that. And a lot of the impinging osteophytes, we talk about femoral acetabular impingement and cam impingement, all of that bone that is abnormal and could interfere with range of motion is on the front of the hip, on the front of the femoral neck, and I'm looking right at it. I don't have to peek from underneath or turn the leg, you know, around to look at it. I'm quite happy with it. There are studies that show the blood supply is better preserved with this approach. As I said, there's no studies that show that the ultimate outcome is any different. So my advice right now for surgeons learning this procedure is do what you're comfortable with. It's more important that you do a great job of getting the implants in perfectly than which approach you use. But you asked me what my preference is, and that's what it is.
There have been some changes, and there's some mentless placement now, different surgical approaches, which you just talked about, more mid-head devices, shorter stem devices, computer-assisted surgery. What do you see happening in the near future or the next 5 years? Where do you think hip resurfacing will be going and how it might be changing?
Yeah. Well, the mid-head device is not available in the United States right now, and I do expect that it will become available in the next few years. And as a matter of fact, I've been asked to be part of the FDA investigation of that device. I think that will expand the indications for patients that do have avascular necrosis or very large cysts in their femoral head. And it still maintains the benefit of not violating the femoral canal. It still provides for bone support and bone loading in the upper femur, what we doctors call the calcar of the femur. It's such important bone that routinely disappears after a stem is placed for total hip replacement and is routinely preserved by hip resurfacing. It seems to be preserved by these mid-head replacements as well. So I think it bears investigation, and I do intend to be helpful and investigate this. And if it is something that is approved, I will probably be using it in some time from now. As far as cementless fixation, first of all the sockets are cementless already. It's the femoral component we're talking about, the ball. Now, in the Birmingham experience, I must say, they have been cementing femoral components for 12 years, and there has never been a single femoral component loosening when the diagnosis was osteoarthritis. There have been some migrations of femoral components in avascular necrosis cases, and indeed those are exactly the ones I think maybe a mid-head device would have been better for, but wasn't available. But what we've learned is that with osteoarthritis, which is by far the most common diagnosis, there has never been a single case in, at least in Derek McMinn's hands, of femoral component loosening. So maybe they'll all come loose at 20 years, we don't know, but they probably won't. So right there you have to wonder, why should we investigate cementless fixation? Because those devices, of course, have a higher early failure rate, which is what we know from cementless hip stems. They do require bone to bond to the implant, to grow into the pores of the porous metal or the titanium. And the other thing that you should remember is that to get that porous surface on the femoral component, you have to heat it. And the more I look at this, it seems to me that the microstructure, the metallurgical microstructure and the carbides that are present in cast cobalt chrome are very important for the hardness, for the durability. These carbides, you know from drills and tools that carbides are hard. Diamonds are carbon crystal. These are very hard. They're about twice as hard as the metal. And I say that just to introduce the idea that if you ever heat this metal, the metal of a resurfacing, in order to do anything, whether it's to apply a porous coating or for some other reason, those carbides go back and dissolve. And if you drop a sugar cube into a teacup and you look in the bottom, I'm not talking about stirring it, but if you look at what happens to the sugar cube in hot tea, it kind of melts and collapses, and it's still there, you can still see it, but the bits are smaller. And in, I would say, most well-designed simulator studies and wear testing and pin on disc and such, you can show that if you damage this carbide microstructure, if you get rid of the blocky, large carbides that confer hardness, then you end up with a softer material. So not only is there really no evidence that cementing doesn't work in the Birmingham, and there's evidence that it works extremely well, so you're not sure why you would want to abandon that at this point. But there is the possibility that the additional heat treatment of adding a porous coating to a femoral component would actually harm the wear properties. In other words, make the metal a little bit softer, a little bit resistant to wear over many years. So I see very little upside, and I see quite a potential downside for the cementless femoral component. On the socket, just to be clear, as I said, they're all cementless, and I would say most of the cementless surfaces on the back of sockets from a variety of manufacturers are added through a sintering or some kind of a hot process, heating, adding titanium or beads or something to the back of a cup. And again, that has the effect of messing with the carbides. And the Birmingham and a couple of others that also have outstanding results put their beads on as part of the original casting. So they call it an as-cast microstructure. They cast this molten metal into a mold that already includes the lumpy bumpies on the back of the cup. That cools down, and that's it. They never reheat it again, and the carbides remain big, blocky, strong, and hard. So
Interesting.
that was a long answer to that
Well, no,
question, but it involves
it's great
other things
information.
that I think are important.
Talking about the metal, there's some patients have heard that there's issue with metal ions and hip resurfacing.
Yeah, that was my main concern too. In fact, that when I went over to Birmingham, been there a couple of times. When I went over there for the first time, I really probably didn't think I was going to take on this technology simply because of the metal ion issue. It's an issue. I can't say it's not an issue, but I think it's an issue that has been looked at pretty carefully, and I'm confident at this point that I'm not doing harm to people by using metal on metal technology. I would say you look at the pros and cons of anything. In our business, everything you do has some plus, some minuses. If I tell you to go on bed rest, too much of that's bad for you. If I give you a Tylenol, too much of that's bad for you. And certainly if I give you cobalt and chrome, too much of that is bad for you too. Let me tell you what I know about metal ions. Anytime you put anything in your body that's made of metal, you find metal ions, and that includes the fillings in your teeth, it includes a plate on your ankle, a total hip, a total knee. What we're talking about primarily here are cobalt and chrome. Cobalt and chrome are already in your body, and so is molybdenum, and those are the three main constituents of a hip resurfacing device, cobalt and chrome mainly. Cobalt is part of vitamin B12. Cyanocobalamin, it's there, you already have it. Chromium is also already in you. It's part of your insulin pathways. You need to have chromium, and you need to have molybdenum. Like anything else though, too much of it is bad for you. So how much cobalt and chrome do we normally have? Normally, we probably have under 1 part per billion, somewhere around 0.2, 0.3, 0.4 parts per billion of cobalt and chrome in our blood. A correctly done resurfacing, and it has to be correctly done, but let's assume it's correctly done, everything's positioned right, will have about 1 to 3 parts per billion of cobalt and chrome in your body. Now 1 to 3 parts per billion is more than you started with, which was about half of a part per billion, or a bit less than that. Our EPA allows 100 parts per billion of chromium in tap water. Well, okay, that's tap water, and we're talking about in your blood, in your body. So there's still a concern. Is 1 to 3 parts per billion in blood dangerous? Well, we don't have any evidence that it is, and we have some evidence that it might not be. There was exactly the same metal put in the 1960s and 70s as a total hip. And in fact, total hips these days are also done metal on metal. But back in the 60s and 70s, just slightly before John Charnley's metal on plastic total hip took off, they were doing them metal on metal with exactly the same as cast cobalt chrome microstructure. And they did a lot of them in some parts of the world. And one place that did a lot of them was in Scandinavia. There's a Finnish study that goes over many decades of the health effects of metal ions from the people who had a metal on metal total hip. It's not a resurfacing now, it's a total hip, but it's exactly the same metal, and they had exactly the same increase in metal ion levels in their blood. And what the Finnish study showed was that if you look at the overall cancer rate of patients who did have a metal on metal total hip, and you compared it with people who didn't, there was no change in the overall cancer rate. And that is one of the concerns, is does it cause cancer? And they looked at the life expectancy of these people, and the life expectancy of people who had the metal-on-metal total hip actually was longer by 2 years than people who didn't. And then let's talk about resurfacing. In England, as you know, they've done an awful lot of metal-on-metal hip resurfacing. That's where it started. And there's a center, an independent center in England called the Oswestry Outcome Center. And they have a study of hip resurfacing now, resurfacing metal-on-metal. Same question, does it cause cancer? And they actually found a drop in the cancer rate in people who had metal-on-metal resurfacing compared to those who didn't. And they found that the life expectancy of people with the resurfacing increased nearly 10 years, which, you know, I gotta tell you, I don't think it's the metal ions that are like chemotherapy and killing all the cancer cells, although there are some metal chemotherapy agents. But I think the life expectancy issue is more to do with the fact that these are patients that are active, that they take care of their bodies, that they seek out great technology for their health care if they can, and it has probably much more to do with that. But now that there's more than 110,000 Birmingham hip resurfacings in the world, which is a lot for any device, that's a lot of information, a lot of experience. It seems clear to me that at least they're not killing people. And there may be problems with metal-on-metal, and I think we can talk about allergic reactions, hypersensitivity reactions, maybe toxic reactions, especially with badly implanted resurfacings. But just the mere fact that you've had a metal-on-metal device seems to be safe at this time. We still do not do it if you are a young lady and you plan to become pregnant. I will tell you, have something else done, because we know that developing fetuses are more susceptible to environmental things as they're making their little brains and things. We know that children are more likely to suffer from lead poisoning than adults are. So, you know, we do have options. We can do titanium, ceramic, we do things as far as hip replacements that do work very well. And it goes along with FDA approvals, is that we will not do it on a woman who does intend to become pregnant, because nobody knows what effect these small levels of ions could have on a developing fetus.
Could you follow up with telling patients what are the positive aspects of hip resurfacing compared to a total hip replacement?
Sure. If you don't mind, I'll talk about the positives and the negatives.
Okay, good, good.
It's all what
We
I
should
said
have both.
earlier. It's a balancing act. But I'll start with the positives. There's many of them. I think the first positive about a resurfacing is that you don't give up 3 inches of your femur to the doctor, to the hospital. You don't give it up. You keep it. Because your problem isn't with your bone. Your problem is that the surface of your bone, the cartilage surface, has worn off. So why give it up? And so the first step in a total hip replacement is to make a cut across your femoral neck, throw away 3, sometimes 4 inches of perfectly healthy bone for the sole purpose of being able to place a stem down your shaft, down your femur. And that stem has only one purpose, and that is to sit still and put the little ball that we put on top of it, keep that ball in one place. That is it. That's the purpose of the stem. Well, we already have a skeleton that fulfills that purpose, that function, to keep our ball in one place. So the number one difference between replacement and resurfacing is you keep your femoral neck, you keep almost all of your femoral head. You might lose a few millimeters of it as far as the preparing process to get the cap on the end of your femur, but you're not losing anything that's worth anything, and you save all that bone. That's on the day of surgery. After surgery, once you've had a total hip replacement, any stem, and I don't care if it's proximally coated, if it has a collar, if it's fully coated, if it's cemented, if it's not, doesn't matter. Anytime you pass a stem down the femur and then put load on the top, the loading is completely abnormal. By that I mean, in the normal situation, our body weight goes down on the top of our femoral heads. You can look inside the bone through an x-ray and see these little stripes that carry the weight of your body down onto the medial or inner thick part of the femoral neck. That's normal. Once you've cut that off and then put a stem down, where do the loads go? You put a load on the top of that little ball, they go down the stem. And instead of being applied to the neck, the stripes are gone, they are applied to the inside of the femur farther down. Now bone is clever. Bone feels these forces, and it feels where it's not being loaded, and it feels where it is being overloaded. And over a period of several years after surgery, you lose bone. You lost it the day of surgery, you're going to lose more bone from your femoral neck for about 4 or 5, 6 years after surgery. And that very important strong bone in the upper femur becomes quite thin. And in many cases you could compare it to an eggshell. So it's thin bone. Correspondingly, the bone in the lower part of the femur picks up strength. And that's because it's being loaded more. So that's okay, and we've known that for 30, 40 years in doing hip replacement. We know what happens. We know that, and it seems to not be a problem if nothing ever goes wrong with your stem. But we're talking about young, active people here. Very young people who want to do a lot of activities, and we know that their failure rate is higher than elderly people. The problem happens if something goes wrong with your stem. The stem could bend, it could break, it could come loose, it could pivot, twist, it could sink, it could get infected. Things happen. Then, if your doctor has to take it out, what's he looking at? He's looking at an eggshell up here, strong bone down there somewhere. And so the redo of a regular length hip stem is very often one of these long stems to capture and get purchase on that bone farther down your leg. And those long stems, we know, do not work as well as the short stems. Okay, bear with me, I'm getting there. So, if you have a resurfacing as your first operation and you saved that bone and you loaded it normally for however many years, if something ever goes wrong with your resurfacing femoral component, your doctor can come along years later, cut it off just like he would do for a total hip replacement, and he's looking at virgin bone, untouched, perfectly strong, actually stronger than the day you had the resurfacing done. Perfectly good bone. And so he can put a regular length hip stem in with the good results that I know they work, as I do them myself. Hip replacements are perfectly good operations. But a failure of a hip replacement requires a long stem. In so many cases, a failure of a resurfacing femoral component is a primary length hip stem. So you're one giant step back from ever needing that long stem. And that's a good thing for young people, right? So that's the number one advantage that I see in resurfacing, is that in young active people who are precisely the group that may fail in the future, the first redo you have of a resurfacing is easy. And if it's easy for me, it's easy for you, right? And then you have a regular length hip stem, and you know that years from now we're going to have better hip stems even than we have now. We don't have to change your socket if it's in good position, if it's not worn. We can put a resurfacing size head on the top of that new little short stem, pop it in. So you've had a redo of your resurfacing for what amounts to the lower half of a single, regular, easy to do hip replacement. That's the number one benefit. There's other benefits. You might have heard of hips popping out. The total hips pop out more than the resurfacing. No question about that. There's probably a 10-fold difference in the risk of dislocation between a total hip replacement and a resurfacing. It's so dramatic that I don't give my resurfacing patients any of those so-called hip precautions. So I let them cross their legs, lie on either side. I let them bend over, tie their own shoelaces the day after surgery, pull their knee up to their chest the day of surgery. There's no restrictions on range of motion for resurfacing in my practice, whereas I still use some restrictions for total hips because it's possible to pop out. So you don't really have to worry about popping out of a resurfacing. It's rare, anything can happen, but it's not the kind of concern that people have when they have a total hip replacement. you're very unlikely to get a leg length discrepancy with a resurfacing. Hip replacements, because we're taking out 3 inches, maybe we put in 2.5, maybe we put in 3, maybe we put in 3.5. And it's not because we're stupid, it's because, again, to do with the instability and the chance of it popping out, we often have to add a little bit of extra length. It's sort of like tuning a violin string. You got to get it to the right tension for it to work correctly. And very often that means that with a hip replacement, you actually have to add a little bit of length, so as a surgeon you're confident it's not going to pop out. You don't always have to do that, but there is more of a chance of a leg length inequality with a hip replacement than there is with a hip resurfacing. And there's more. People who have had a resurfacing, if they are inclined to be very physically active, they are considerably more likely to reach that goal with the resurfacing than with the replacement. And not only that, but their doctor is more likely to permit it. There's a lot of different ways that we measure the outcomes of hip surgery. Things like this hip score or that hip score. But a lot of those hip scores are dated, and they don't actually ask directed questions about how really active you are. One of the questionnaires, if you will, about activity is the UCLA activity score. And pretty routinely, when people look at the high-level activity of a patient who's had a resurfacing, is better on that score than it is with a hip replacement. And as I said, your doctor is more likely to let you do that too, because he's not so worried about it popping out or wearing out in cases of plastic or breaking in cases of ceramics. There's also studies that talk about gait and balance and something called proprioception. And that's probably goes together with why people can get back to sports. Proprioception is that sense we have inside our bodies that if you're in a completely dark room, you know where your arm is, all right? Because you know. That's proprioception. But of course, we don't use that sense to know where our arm is in a dark room. What we use that sense for is to walk on uneven ground, slippery sidewalks, wet pavement, down a hill, ice. So moment to moment, and athletes do this all the time without thinking, you know where your joints are. And it makes sense to me that proprioception is better maintained with resurfacing because, as I talked about earlier, the loading of the upper femur is completely normal. And that bone is still there. 3-4 inches of bone, which is full of nerve endings, is all there. So if your proprioception, balance, and gait are normal, that allows you to get back to these higher levels of functioning that perhaps a more elderly person really has no interest in. So hip resurfacing is not for everybody. Hip resurfacing is for people who do intend to be active, who do have good quality bone, who are younger, and they're the ones that can take the most advantage of it. Well, those are the advantages. The very large head is also an advantage as far as lubrication. I can't tell you that your range of motion will be better with a hip resurfacing because range of motion depends on a lot of different things. One of them is head size, but another one of them is the diameter of the neck. So if you were going to put something on a simulator and see who's got the best range of motion, a huge resurfacing head on a skinny little total hip neck will actually bend farther before something bumps into something else. But I can tell you that a hip resurfacing done correctly will put you back with a proper surface on your regular femoral neck, and it should at least be normal range of motion. Unless you do some little lifting and turn into a pretzel, you probably don't need more than normal range of motion. Now, the downsides. I talked to you already about metal ions. I do still consider that a downside for some of the unknowns for that issue to do with women of childbearing age, for people who might have allergies to metals, and for people who have bad kidney function, because it's your kidneys actually that clean the ions out of your blood and keep the levels down to 1 to 3 parts per billion. So the ion issue, the metal issue, is still an advantage, but if I'm going to use metal on metal and have that supposed concern or disadvantage, I want to get something for it. And I think you understand from what I've been saying for the last few minutes that you are getting something for it with resurfacing. But that's the reason I don't do it in a regular old total hip replacement. You're not getting anything for it. You can get just as good, if not slightly better, wear properties with ceramic on ceramic. So if you come to me and you're otherwise a perfect candidate for a resurfacing, but you're not going to get a resurfacing for one of these reasons, then you're going to get a ceramic on ceramic titanium total hip. So the one disadvantage of the metals, pretty well explained what I think about that. The other disadvantage is much more practical. Because you still have a femoral neck after resurfacing, you can break it. And that is actually the main early failure mode of hip resurfacing. It's called femoral neck fracture. You don't have a femoral neck anymore, you can't fracture that, so it doesn't happen with total hip replacements. Although, believe me, you can still fracture femurs pounding in these wedge-shaped stems into young, strong bone. But let's talk about resurfacing and femoral neck fractures. In most series, it's about 1 to 1.5% in men and about 3 to 4% in women. It's more in women, it's about twice as much in women, and that's probably because women generally have smaller and weaker bones than men do of a given age, generally. And the way these femoral necks fracture is the way a paperclip fractures. If I give you a dry twig and I say, here, break this twig, you're going to crack it over your knee, done, broken. If I give you a paperclip, you can't do that with a paperclip. You can't stomp on it, hit it with a hammer. You can't break it. The only way you know how to break a paperclip is to bend it back and forth, back and forth, back and forth, too many times, and it cracks. And generally without warning. That's the way these femoral necks break. So my advice is don't do too much too soon. Let your bone heal. Once you shave off just 1 millimeter or 2 or 3 of bone, you have weakened it. Even though you then cap it with metal, together the metal and the sawn off bone is a little bit weaker than it was yesterday. But bone is smarter than a paperclip. Bone knows that it's weak. Just like when it knows that it's being loaded, it adds more calcium, and when it's being unloaded, it loses calcium. It knows when it's weak. So I'm going to tell you to drink your milk, get your sunshine, take your vitamins, take extra calcium, live a nutritious, healthy lifestyle. And over time, your bone, where I sawed it down and weakened it, will come back. And it comes back so well, it actually comes back stronger than the day we started. So by the end of 12 months, you actually have more bone density in your femoral head and neck than when you started. And so most femoral neck fractures, they don't happen the day of surgery like they do when you're putting in total hip stems. They happen when you're getting back to things, when you think the operation is all behind you, you don't have any pain, you're back to doing this and that, running around all day, maybe doing the sports, the heavy lifting, your heavy work. That's when these fractures occur. Just like the paperclip, repeated loading of your femoral neck more than it once before it's ready can crack it. So limit what you do. Be smart. You can walk, you can cycle, you can golf, you can swim. Live your life, but don't go to the gym and don't do leg presses, okay? I have had 1 femoral neck fracture out of these more than 450 patients. And my one guy, it was a guy, not a woman. I have no femoral neck fractures yet in any women. He was in the gym 8 weeks after surgery, feeling great, no pain, wanted to whatever in the gym, lay on his back and started doing leg presses. And if you think of that paperclip and put that in your hip joint and bend these heavy weights, push these heavy weights up and down, he just snapped it. And he ended up with what I said earlier, which was a stem, a big head, inside his resurfacing socket. He's happy now, but I'm sure he would have preferred not to have more surgery, and he was a believer in resurfacing, and now he doesn't have one. So if you take care of it, it should be fine. There's various technical things from your surgeon's point of view that are important for fractures. If you grind the head a little bit in the wrong place and you damage the top of the neck, that's a big risk factor for femoral neck fracture. If you put it in on the wrong angle or put in the wrong size, or there's things that we can do that predispose you to femoral neck fractures. You could have weak bone, you could have osteoporosis. I'll get a bone density test if I'm concerned about that. You could have a big cyst in your femoral head or neck that clearly is making it weak. But properly managed, properly spoken about, if you hear me what I'm saying, you will probably not have a femoral neck fracture.
Well, thank you very much for the interview. I know prospective patients will learn a lot, and I think even post-op patients will listen to this and they will learn too.
Sure.
Thank you, Dr. Brooks.
My pleasure. You've got a great website. I
Thank
think
you.
you're doing a great service.